Thank you, Ujjwal. Thanks for coming in. I'm sure the lunch was pretty good. Okay, it says the lunch is pretty good. I'll try and then not put you to sleep. So I'll try and then make justice to the 10 minutes that's given to me. Before I start, I would like to say something about Columbia Asia. We've been in the healthcare provisioning space for the last 20 years. We started our journey in Malaysia. But then we started our footprint in India in 2004. And our first hospital was in 2005 at Hebal here in Bangalore. To date, Columbia Asia has about 11 hospitals in India. And we are the first integrated operations with IT as a technology backbone. So we kind of reinvent ourselves every 3 years' time and then try and then adopt new technologies to move forward. Columbia Asia has three unique principles with itself. One, it works on a lean staff model, it works on an asset-light model, and it works on integrated operations. These three pillars are the philosophies kind of gave the impetus to the IT systems that what we have, and which gave us enough amount of thrust to invest and then proposition. So Columbia Asia today owns about 6 IP technology platforms within itself. It kind of worked with multiple partners to create these solutions and then deploy it over the years. So for the last 10 years in India, every single medical record is digitized from the day. So it's all electronically entered by doctors, used by them, prescribed and all that. So that's the little background of what Columbia Asia is. For the next 10 minutes, I'm trying to kind of help you come across the journey that what we have been through for the last 18 months within Columbia Asia, trying to adopt the digital technologies of the entire patient experience platform. The way that I've kind of put through a few slides is to kind of set a context as to why and what is the reason for us to get into this digital journey and how does it add value. So the couple of references that we took from the industry was one from the Accenture study in May 2016, which kind of said patient portal is the way that new age digital health delivery that's going to happen. So the snippets of what it is being displayed on the screen, so I will not take time in reading it. The next one that we latched upon to see whether is it the right investment for us to go through, because every tech investments go through a hype cycle like what Gartner is presenting every year. So when we looked at at the fag end of 2017, we looked at where does the entire patient experience and portal platforms are. We kind of understood that it's at the plateau based and it's kind of much accepted by the patient as a community. So these two kind of reference points gave us the confidence that yes, we should look into it as one of the journeys that what we need to go through. So when we started our journey, we looked at not like kind of upgrading our current systems to move on. So we said, this is something going to be the future. So let's start from the scratch thinking as to what I need to change from a process standpoint, from the whole ecosystem in terms of integrated system and delivery, what you need to do for patients. So unlike the other enterprise systems where you kind of look at who is the persona, whether it's a finance manager or a CFO. But in this case, we kind of looked at, okay, this is more to patient for him to feel experienced. So we kind of wore the hat of patient and then looked at what would he be going through. So when we looked at the hops, what patient does through in a healthcare journey, we looked at about 11 different steps that what a patient would think or go through. And then we kind of took each step and then started walking through in terms of how do we need to re-evangelize the whole process and re-engineer it to make it more digital savvy rather than kind of augmenting it with an automated IT ecosystem. Yeah, so that's how we looked at it. So I'm not going to go through all the 11 steps more in detail, but just a couple of steps to kind of help you understand. The text content on the left side of the screen explains what a patient will go through, how he will think, what kind of actions that he would do. And the gaps are the sections that what we had gaps within our own Columbia Asia enterprise. So we kind of identified these three. One, what's his expectations. Two, what we have as gaps. And what the new age technologies can enable this whole experience journey to do. So the options of what he would be expecting and how we can augment those features are on the right side of the screen. So for every single process point or the think tank of a patient, we looked at what is the course of action that we need to do. So that's how this whole journey is being mapped. So for the first step, when he's kind of looking at something, what would he think? What would he want? So how would we kind of manage different set of engagements with the patient? We did not look this whole platform from a pure health delivery standpoint. We looked at more from an experience to say, like if he hops into a retail store, what would he look at? Okay, there is something that he only wants an information, where he looks at it, okay, I don't want it, and he moves on. So what are such information that I need to provide to him? What are such things that where he would pick up in his hand, look at it, like to experience, but then he will stay on it and then do it sometime later. So we kind of looked at all those and then planned each of these steps in the journey that what we need to do. The second journey is once he decided, yes, I need help, what would he do as actions? Okay, I'll just pause until she finishes taking up the chat so that you guys can read the end. So we kind of identified the different touch points that what we could do on each of the actionable technological input interaction between a provider and the patient. So all these points that's in the right hand side kind of tells you which is that experience that you can give through what technologies that what you can, right? So the third step is about when he arrives into the hospital, what you actually deliver and then get things going. So this is how the 11 steps that we said. It starts with symptom, then it goes with the kind of how do you engage with the appointments. Then he arrives into the hospital, he gets a treatment, he gets diagnosis, right? And he gets a consult from the doctor. Either from consult, he gets into the admission, or he gets discharged, or he gets into wellness and he goes home. So this is the kind of full 11-step cycle that we reviewed. And we kind of said, okay, which are the options that we need to do? So the way that I kind of said earlier, we kind of looked at more from a patient-centric standpoint rather than what a hospital should look at providing for a patient. We looked at what would patient want, and then how we can provision that. So that's the kind of lens that we looked at it. So we kind of said, okay, these are some of the basic features that must have, so that which paves way for multiple other engagements that you could do with the patient. The next set, for the same set of stuffs, once we know our patients are able to appreciate and understand these new age technologies and explain, we said what are the other additional features that we could give, and we kind of bucketized that into the second bucket of advanced or the next set of care related stuffs. Then third, we said these are all the premium set of features where you do continuous engagement with the patient on chronic disease management or a long-term retention customers, that how do you want to feel. So that's how we kind of split our journey and split our feature sets that what we need to provide for our patients. I just want you to guess to how many bullet points that you saw in each of those 11 step of journeys. Is there any guess, the number of bullet points? Oh, you're too much. Okay, we have about 50% of it. About 70 is the total set of features that's available there. So what we did is we also did a kind of investment rational study to identify which feature should I put in first, which one I can defer. So we looked at 7 pillars of decision-making factors, right? From revenue increase, operational efficiency, patient experience, clinical outcome, and the impact on our change management cost and how do we kind of operationalize it. There is some amount of cost that you need to develop every solution, and there's some amount of cost that you would incur recurringly to deploy and operationalize each of these. So we looked at all of these and identified in a scale of low to medium and said what would add value. And this metrics of measurement gave us to decide what is basics, advanced, and premium in terms of features, while the terms of basic, advanced, and features are more just coin, but basically we decided into phase 1, phase 2, phase 3 in terms of deployment to patients, right? So those are the 70 features. I've kind of cut a couple of slides for time. So what we also thought around this age is we wanted to give them an omnipresence experience across every single channel that they interact with us, be it a mobile platform or a web platform or in-person experience or a telecall center. So we kind of created this entire solution on a multi-channel platform so that whenever a patient kind of calls in or walks in, he has through the same experience all throughout. the way that we looked at the entire platform to roll it out, we said, okay, there has to be some performance measurement that how do we need to look at it. So we defined what are those key performance metrics that we look at it. So we divided that into two. One, what should business look at it to kind of measure and see the adoption through the entire platform, and what should as the metrics that we need to look at to successfully roll out these platforms. So those are the things that we kind of measure. So right from the first month of this entire project, we started measuring each one of them so that we kind of see through the whole platform in about 8 months from the day we conceptualized the idea. Some of the references that which helped us to plan through this 11th step of journey, so which helps you to. So the last 5 minutes, I leave the floor to open to ask any questions, if there's.
Case study. So I've been building a SaaS platform for the healthcare, predominantly for the US market. So now predominantly all the EHRs and EMRs have a patient portal of its own, right? And at least to what I know in the US healthcare ecosystem, the adoption of the patient portal, right, is not that high, right? So I have a question that is twofold. One is, while EMR, EHRs are already having a patient portal, right, how well do we see these independent patient portals actually gaining traction, right? One is that. And number two, then obviously when we have an independent patient portal, then there's a question of integration and carrying patient information from one place to the other, right? So how did you get to handle these two challenges?
Like I said at the beginning, we are a lean staff model in terms of operations. I personally don't like any of my colleagues in the organization entering the same data twice in 2 different platforms. So we started our entire journey with the integrated platform. Our EMR is extended through this experience journey platform, and it has middleware which connects through the Mirth Connect engine. And we use the HL7 protocols to interface. So every single interaction with the EMR and the HIS happens through the Mirth engine. And it's an integrated platform. It's not an independent portal by itself. Though the solution is capable of standing on its own, the way that we have deployed is the integrated platform. So if you book an appointment for your own self, you don't need to come into our front desk and say, I have booked an appointment. The moment you present yourself with your MRN number, people will know which doctor you're trying to meet.
So your scheduler, your patient chart, all of them comes via your Mirth Connect from your
yes.
EMR system onto your platform?
Yes.
Okay. Some of the EMRs that you could?
The EMR is a custom-built EMR.
Oh, you have a custom-built EMR that you've integrated with.
That's
okay.
right.
Yeah, that was my main question. Okay, thank you.
With regards to patients with chronic illnesses, you mentioned something about chatbots and symptom checkers and stuff like that. So is there specific capabilities that you have built into the system for handling chronic patients outside of the hospital or in between consultation and in order to keep in touch with them, also giving them the right advice while they are not in the hospital? And the same thing for post-discharge as well.
At this point in time, the operationalizing model does not have a real-time integration or interaction between the patients and the providers. The platform is capable of accepting data from the patients and pushing it back to the doctors to kind of intervene and then make necessary care interventions to happen. There are legal constraints that we have to work with in terms of acquiring non-hospital generated data and the usage of it. So until that gets cleared, I would not be operationalizing it, at least in the near future, the next quarter. But however, the way it was envisaged is that there's going to be a live chat line between the doctors, and there would be critical alerts that comes in through the app to the doctors for them to intervene and then have live chats back to the patients. So that's what's enabled.
So my question was also in terms of there might be, so yes, doctor-patient interaction and provider-patient interaction is a big part of what we need to kind of make it easier. But what about advice that the patient needs that can be provided either by a knowledge engine which is based on some protocols or advice which is non-provider, not originating from a provider, or it may be from an artificial intelligence engine, or it may be from a chatbot which kind of understands the basic protocols of management for a chronic condition, and you can give the patient advice which is relevant in that moment when the patient needs it.
From the care intervention standpoint, it's the EMR that's going to make the job. Our EMRs are connected with up-to-date repositories and the SIMS protocol engines. So the EMR communicates to the physician, and physician then communicates with the patient. So we kind of, we didn't live it such way that there's going to be a pure technology interaction directly. We still wanted the human touch to be there, being in the care provisioning space. So we kind of enabled the doctors to kind of consume the information instead of searching for the information.
Last part, any aspect of remote care or remote monitoring which has been integrated today in the system?
We do teleconsults and tele-ICUs, but not on a large scale. That may take some time to kind of see through in terms of large adoption.
All right, thank you.
Yes, Chair.
You had initially mentioned, maybe this is building on what he asked, that you wanted to focus more on patient experience rather than on care provisioning. What was the reason to choose it this way? And could you talk a bit about that? And where does it actually draw the line?
I might be self-professing for Columbia Asia, but Columbia Asia is known for its quality in terms of patient care and the outcomes that we focus on. So we kind of felt that that's given to us, and we wanted to look at more in terms of how do we make the engagement experience more better. Because our EMRs kind of, right from day one, I've not seen many of our patients carrying through a bunch of files and papers when they walk around. So the history is lifelong with us. We have all the last 10, 12 years of history real-time available for the doctors on their query. So that way, from my standpoint, quality care is given. You can't debate with it. So we kind of moved on to say, how do I engage with them more? The other point that we also looked at is, I as a patient will feel comfortable if a doctor touches me and says, yeah, there's no fracture, it's only a ligament tear. So we didn't want to take away that human element out of it. So we said, okay, if I don't want to touch the core, I touch the peripheries to kind of enable the care to happen faster. So that's where we focused on. Otherwise, your adoption is something that you will fight giants across. I hope no doctors on the floor, but still, yeah. Any other questions?
I have a question. When you said you are completely integrated across, starting from inquiry level up to your HIS and EMR standpoints. So I believe the doctors would be entering things into the EMR and HIS system here. What is your outlook? I mean, how do you believe that, I mean, what is the adoption level of doctors when they have to fill information into the EMR and HIS?
Okay, good question, but each one of us have different perspectives. So how do you define adoption? Or how do you want to understand adoption?
In terms of their keenness to enter and the time spent to enter such data.
Okay, I'll take three different metrics to kind of explain that. One, our CPOE compliance percentage is about 93% in the OP scenario and about 78% in the IP scenario. Why is it lesser in the IP while you can control more in the IP scenarios? Because we've kind of cautiously chosen both our ICUs and OT to be primary on the paper base because their response to stimuli in terms of actions is much faster. But the data gets digitized at the end of the shift by each of the nurses that they're working around. So that's why the difference in terms of pure adoption ratios. In terms of our initial assessment screening, either by the ER physicians or by the admitting consultants, we stand at 99%. And our discharge summaries are 100%.
Okay. Thanks.
Yeah. Thank you for the talk, doctor.
Sorry, I'm Mr. I'm not doctor.
Okay. Could you tell us how this system has been received by the patients and how it has improved the workflow in your hospital?
It's a mix of both. We did have initial days of challenges identifying a patient uniquely. While we have HIS systems right from day one that we operated in India, we did not have one single unique identifier to identify the patient, though we had our medical record numbers. So we had to go through a sort of series of parameters to map and then bring in. So we had duplicates in the ecosystem, which kind of built us legacy for the last 10 years. So it will take some amount of time to clean it up. But if you want to see the real feedbacks, please log on to Google accounts, and when you download, you will get to see the reviews at what you have. That will say where we stand. But from an adoption standpoint, from the day we rolled out in 2018 April, we have kind of ported about 2.9 million patient records in it. And at any point, any month, for a period of 30 days time, we have an active usage of about 30,000 patients using it. And we have about, so far, 1.5 million patient appointments booked on the platform.
And is it, is it something which only Columbia Asia has right now, or is it something which other competitor hospitals also have, and how is it?
Each one of them have their own. It depends upon what their HIS is, what their processes are. We have kind of latched onto our processes. So I think most of them have what they have.
So I came in late, so wanted to know if patients come in with reports or diagnostics from outside the hospital. Is that also entered and integrated?
We don't enter it because we'll have to preserve the source of the information, so it gets scanned and then kept as a record. Yeah, thank you so much.